In that discussion, you talked a little bit about what sounds like kind of a natural remodeling that occurs over the course of the first 3 to 6 months. Is that one of the mechanisms of pain relief? And you spoke about another mechanism of pain relief. And the third I would like to ask is the initial mechanism of pain relief, does that come from the redistribution of the load being transferred back over to the lateral compartment, more and a more even dispersion of weight now?
I think actually it does, Tom. The interesting thing that we've noticed over time is I followed these patients up, many of them for years now, and I find that although one might be concerned about essentially a transition to the lateral compartment of some of the pain generators or even some narrowing of the lateral joint space, I've not seen that. These individuals who tend to primarily bear weight preoperatively at the medial compartment much greater than the other compartments still bear their primary weight at the medial compartment. So I'm not seeing any type of collapse of the lateral compartment. Most importantly, as you asked, I am finding that the pressures within the knee seem to be much more distributed evenly, much early, compared to how these individuals have been. They're kind of transitioned back in time where the knee pressures are redistributed and the knee tends to articulate much more like it had years ago before that medial cartilage essentially has started to evaporate. Okay. So I think the pain relief comes from the fact that we're not any longer seeing bone-on-bone pain, or we're not seeing rough cartilage articulating with rough cartilage pain in that medial compartment. We have a spacer now within the knee.
Great. With regard to patient expectations, is that a discussion that you have with people? Are there other things that you utilize as a tool to help them with that? It seems to me that that's a extremely important discussion and or kind of mind travel that a patient has to go through prior to surgery so they can set themselves straight as they start to go through the post-surgical follow-ups and therapies. Can you elaborate a little bit more on what they might expect from a post-surgical therapy follow-up to help with that those expectations?
Well, you're correct. That was actually a learning curve of mine because it's the old story, a picture is worth 1,000 words. And so I've learned that I really need to, in fact, I've done this for years now, bring forth not only models, not only pictures of what an osteoarthritic knee looks like, comparing it to their preoperative x-ray, but I'll show them a model. I'll show them a three-dimensional model prior to and with an OrthoGlide implant within the model. They understand much better preoperatively what the plan is with the use of those models. Therefore, their expectations, they just get it more. I've learned that in the past, I thought individuals understood preoperative planning, and you have to compare that to postoperative expectations, whether or not we're talking about replacing a knee joint or unicompartmental. The same certainly holds, if not more, with a novel implant. So therefore, especially with such a new implant, even though the results have been tremendous, I find that it's very, very critical to show individuals these kind of models prior to, even after their procedure, and equally, if not more important, when these individuals tend to, on occasion, develop a flare-up in their knee, which they can with overactivities, they still have their own natural knee joint, then I will bring out the model again. I'll show them and remind them what kind of pain relief we've already been able to accomplish by placing this metallic spacer within the knee. And then I will remind them what we can do to treat these short-term flare-ups. We usually will use the anti-inflammatories, the NSAIDs, if you will, and we'll use the viscosupplementation. Once we get them through, again, reminding them that they could go back short-term, very short-term typically, to an assistive device, and we remind them that the effect of viscosupplementation oftentimes takes a few weeks, but once we get them through these little glitches of flare-ups. Then they're back to their dramatic pain relief. And we also remind them exactly where they were. We ask them, do you remember where you were prior to surgery? Right. Once we sort of jog their memory, they remember. They're very happy compared to where they were. And equally important, we haven't burned any bridges.
Which is always a good thing. Surgically speaking, is there an advantage to an implant like this from maybe being able to perform it in a less invasive environment and utilize a varied type of anesthesia, such as local anesthesia? We've had some experience now with some of our surgeons who have been performing this under local anesthesia and having some great results. Can you speak to that for me?
Sure. I think it's optimal to perform this in a surgery center in an individual that's otherwise healthy. I have never experienced any significant issues such as bleeding issues or anesthetic-related issues. I tend to, of course, obtain medical clearance on the appropriate individuals, but I've never experienced an issue in which I regretted having performed this essentially as an outpatient. There are some individuals that, because of pain tolerance, they typically would have a low pain tolerance, that we do like to have the ability to keep them overnight in a facility if needed. But certainly these procedures can all be done on an outpatient basis as far as being done under local. I think local plus or minus some sedation is a very easy and valid and reproducible way to do these procedures. Certainly they can be done under general anesthetic or spinal like any other knee procedure, but this, of all other types, compared to other types of procedures, is very amenable to a local plus or minus sedation. I think this is due to the fact that we just don't have to make the major bone cuts. We don't have to place cement, which can have some risks in their knee whatsoever. And again, it's incredibly minimally invasive. With arthroscopic surgery is how I do it. I do it with an arthroscopic procedure, which I can typically do under local or sedation, and then just adding a very small 5 centimeter or 2 centimeter incision, depending on the patient, just to get the implant in. It all can be done. It's very, very minimally invasive, about as minimally invasive as you could possibly envision.
Thank you. Kind of a last follow-up question just would be, I'd like to just revisit what you see as the ideal patient profile for this product and procedure.
The ideal patient profile is individuals that may or may not have even had arthroscopic surgery and have been felt to be needing more. They need more than just a little trimming of their cartilage. These are individuals that have articular cartilage damage and that are not at all felt to be optimal for knee replacements. These are patients that typically would be considered for, if not bracing, let's say they're past bracing, they would be considered for knee replacements as a last resort. They'd be considered for unicompartmental as a possible consideration. They'd certainly be considered for a proximal tibial osteotomy, certainly a much more invasive procedure in general. So the ideal, typical, prototypical patient is a somewhat middle-aged individual, although this certainly is amenable for individuals typically in their 30s if their knee is appropriate. This also can be applicable for elderly patients who either are not candidates medically for a knee replacement or just don't want to go through one. So the most, if I really had to isolate on the most typical individual, it would be a 50-year-old who is still quite active, who wants to maintain that activity without worrying about their knee implant subsiding, an individual who is larger than ideal body weight, such as an individual who would prematurely tend to wear out their knee implant because of being so large, or an individual that's generally a combination of all three, relatively young, relatively active, and or relatively large, individuals who primarily, if not exclusively, have medial compartment, but of course the OrthoGlide also comes in a lateral compartment, and I've done a number of those, but they have unicompartmental generated pain with no significant involvement symptomatically from the other compartments. This is a very important point because I've experienced the majority of my patients have radiographic patellofemoral involvement. However, I've determined, based on their history and their exam, that they don't have symptoms at all, or at least not significantly, from the patellofemoral joint. Those represent the majority of people that I've successfully implanted OrthoGlides in, and they've experienced dramatic unicompartmental relief because that's where the pain has been generated from in the first place.
Well, thank you. And this concludes our questions. I want to thank Dr. Trotter for sharing his experiences and his past input regarding his procedures. Thank you, Dr. Trotter.